Hello and welcome. Today we're going to present a project we've been working on for a considerable length of time. Primer on thyroid carcinomas. The majority of this work was done by Dr. Hui, Dr. Vuong, one of my friends and colleagues, with a great deal of assistance from my colleague Elizabeth Gillies, who's particularly expert in this realm of pathology. But our goal is directed towards residents and helping you to gain a solid understanding of the differential considerations of different thyroid carcinomas. So our goal is that by the end of this lecture, and after reviewing the digital slides, which we will post the link to with this video, you'll be able to recognize and differentiate the major types of thyroid carcinoma quite reliably. Of course, first of all, it's important to recognize that thyroid carcinoma is the most common endocrine carcinoma, and that it has been increasing in frequency. It tends to be a female disease more than male disease. And most of the tumors are differentiated thyroid carcinomas, meaning papillary or follicular types. And so they tend to have a good prognosis, and thus prolonged survival is possible. As we mentioned, there are two primary types, but there is a second type that is involved as well. The two most common types evolve from the follicular epithelium of the thyroid, but the C cells are also responsible for a certain portion of medullary carcinomas, which we will touch on at the end. Within the follicular cell-derived carcinomas are papillary carcinoma and follicular carcinoma, the well-differentiated or differentiated types of thyroid carcinoma, and then poorly differentiated carcinoma and anaplastic carcinoma, which are really variants of this, or progression molecularly wise of these differentiated types. And of course, these correspond to the normal structures that we see in the thyroid, the follicle lining cells and the occasional C cells in between. So papillary thyroid carcinoma is where we'll begin. It's the largest portion of these tumors. It is the most common thyroid cancer subtype, and usually presents as some sort of a mass, usually a cold nodule if radionuclide scanning is used, and in a fair number of cases may present initially as a nodal metastasis. Because it's a well-differentiated tumor, a slow-growing tumor, and is often surgically resectable, it tends to have a favorable outcome. So how do we make the diagnosis? Well, this is an important thing to understand, that with papillary carcinoma, it's the nucleus that matters. And the features we're looking for in the nucleus are some enlargement and irregularity of shape. A lot of overlapping results from that, bumping up against each other and taking up one another's space. The chromatin tends to be centrally cleared, somewhat marginated, and when identified under H&E staining, routine fixation, it can sometimes have a glassy appearance. The nuclear membranes likewise have abnormal features. The contour is irregular, it's bumpy, lumpy, and there may often be identifiable grooving of the nuclei, little linear streaks along portions of the nucleus that become evident, as well as nuclear pseudo-inclusions. Now, mind you, these abnormalities are subject to fixation, so you do not always see these on frozen sections, for example. And that's perhaps one of the reasons why frozen section is not highly recommended in thyroid carcinoma evaluation, particularly in the setting where you may have had a prior needle aspiration. It doesn't tend to add any additional reliability to that diagnosis. So other things that we may look for, of course, are the colloid tends to be quite dense and sticky sometimes, hypereosinophilic. It may have a particular pattern of scalloping at times. Samoma bodies are identified more frequently with papillary thyroid carcinoma. And of course, the word papillary means that many of these variants, many of the manifestations of this tumor do form small papillae that, as they become less vascularized, can lead to the formation of seminal bodies. Additionally, the stroma can become hyalinized and frequently is hence calcified as that. Papillary carcinoma will often have an infiltrative border, either invading through a capsule if it's risen in a encapsulated lesion, or even vascular invasion. And cystic changes are also frequently noted. So here's a nice example. We see normal thyroid parenchyma out here. And then here in this pole, we see a hypercellular, slightly bluish nodule. As we come into higher magnification, we see that this tumor does seem to be making colloid. We can identify right here that there is capsular penetration, invasion, and destruction of that capsule. So we're pretty convinced that this lesion is a neoplasm and probably one with some malignant potential. And then as we come to higher magnification, we can see that these nuclei, they're bumping up against each other, they're overlapping. They have the features of papillary carcinoma with occasional grooves. Here's a few grooves. And there's some macronucleoli. And if we look around a little bit further, perhaps we'll find a little bit of clearing centrally, and maybe a nuclear inclusion or two we can identify. Let's see. But you can get a feel for these, and we'll show many other examples as we go through this process. So these are the features, nuclear-wise, of papillary carcinoma. Let's go on to another example. Here's one with an adjacent lymph node. And here's one where we can see quite nicely papillary architecture, such as right here, a little papillae and projecting into this space, as well as follicular structures in the background. And again, the nuclear features here are those of papillary carcinoma, nuclear clearing, some grooves, and nucleoli, hyperchromasia to these nuclei. And, just for comparison, let's see if we've got some normal thyroid epithelium over here. You can see here that in contrast to these nuclei, which are smaller, rounder, more widely spaced, and not hyperchromatic, that the nuclei of papillary carcinoma will jump out at you and become a recognizable feature, oftentimes from low magnification. Just comparing those two. And again, here we see invasion or infiltration into the surrounding thyroid tissue. So here's a normal follicle here, follicular structure that is now surrounded and engulfed by papillary carcinoma, which is moving towards the other tissues that are available here. Here's another example. Here we see at low magnification this calcification and some of the sclerosing appearance of this tumor. You can see the very dense hyalinization. And so sometimes you will be tempted to wonder about, well, is there amyloid here or something like that? That is a consideration if you're thinking possibly of medullary carcinoma. But medullary carcinoma has different nuclear features. Here you see a lot of clearing. You see this dense hyaline, almost hyaline-like sticky colloid with some scalloping, and certainly a lot of nuclear clearing and inclusion type bodies being formed by these nuclei. Looking a little further in this case, again, we can see invasion into the surrounding thyroid parenchyma. This one is not an encapsulated tumor, and so it infiltrates in the tumor. And here we see early extension beyond the thyroid capsule into adjacent tissues, nearly into fat at this stage here. Here is possibly a lymph node. We can see a little bit of residual lymphoid architecture here, and the tumor has replaced portions of this node, again with this pattern of sclerosis and nuclear atypia and the follicular patterns of this tumor. So notice I'm not emphasizing papillarity as a primary feature, even though that is in the name. And that is because there are many of these variants where the papillarity is a very minor component. Here's another feature sometimes seen. These giant cells in the colloid sometimes are a feature of papillary carcinoma as well. And then another example showing here the cystic change that you can see sometimes with this. And here we see some nice papillary structures and nuclear atypia associated with this. We may have some psammoma bodies. Certainly there's some psammomatous type of calcification here. And then here's more papillarity right here. We see that, and here, very nice illustration of the papillary architecture features of this tumor. Again, the nuclear features, atypia, nucleoli, not as much clearing in this case, but here's a little nuclear pseudo-inclusion. Here's a psammoma body that's calcified, another one here. So again, this fits nicely with enough criteria to call this papillary carcinoma. And again, you may benefit from coming back and comparing these papillary predominant with the follicular predominant patterns and so forth, so that you get a nice feel for the nuclear atypia, the features that we're looking for in the nuclei that will give us that diagnosis. Yet another example, again with more sclerosis, a little bit of follicular type architecture, the sclerosing pattern, and the characteristic nuclear features, sort of dense colloid is seen, nuclear clearing, and nucleoli, some overlapping occasional grooves, all evident in this lesion. Of course, as we study thyroid carcinomas, you'll want to become familiar with the staging criteria. I'm not going to emphasize that in this lesion, but you'll notice that we've inked the margins. Margin status is important. Here's again another example of a lymph node with involvement by this tumor. As you can see here, lymphoid tissue out here, and nice papillary architecture with this neoplasm replacing a portion of the lymph node. So the nodal status is important, margin status, vascular space invasion, we always evaluate for those features, and as well as size. Sometimes these tumors can be multifocal, and of course that has led to particular manifestations, or certainly surgical approaches. And many times these multiple foci are small foci in other lobes or other areas of the thyroid. And here's an example of such a lesion, fairly small lesion. And this one looks a little bit almost granulomatous, very fibrotic here, as we see. But as we look a little further, we can see we've got some giant cell reaction to the colloid. But amidst this, we've got normal thyroid follicular epithelium here, abnormal follicular epithelium over here, with the crowding, clearing, and other features, nuclear features that we associate with papillary carcinoma involved with this. And so sometimes getting a little bit of a granulomatous response may be confusing. We shouldn't be thinking of granulomatous thyroiditis until we have excluded papillary carcinoma. And as we've mentioned, sometimes that can be multifocal. So a little bit subtle in that particular slide. Here's another example. This one with a little bit of lymphoid stroma here. And as we can see, quite eosinophilic or oncocytic type cells. There is a Hertel cell variant of papillary thyroid carcinoma. And this one is not that necessarily, but you can see that a lot of these cells are quite oncocytic, a lot of eosinophilic cytoplasm. To some degree, these are a little bit on the tall cell side of things, and sometimes tall cell morphology is important if you have a significant percentage of that, and we'll discuss that particular variant here in a moment or two as well. But this mixture of solid and so forth is also a variant. So here we see a nice nuclear inclusion there, and the other nuclear features of papillary thyroid carcinoma. A lot of Samoma bodies scattered amidst this tumor. And here in the other sections, I think we can see some more conventional type of morphology here, almost papillary structures, follicular structures. And of course, invasion beyond the thyroid. Here's some conventional papillary architecture up there. Here's another feature, clearly a malignant case. And in this situation, we're just showing you a portion of that with several tracheal cartilages. And we can see that here the tumor is actually penetrating between some of these cartilages and into the tracheal tissues. Here's the pseudostratified columnar epithelium, tracheal seromucinous glands, and here we have a neoplastic proliferation. And as we look at higher magnification, it has the nuclear features and a sort of follicular pattern that would be consistent with papillary carcinoma. Now, why is it not follicular carcinoma since we're making follicles? Well, it's because of these nuclear features with the nucleoli, with the grooves, the clearing and inclusions. Additionally, we have, at least right here, a nice little papillary structure that certainly also goes along with papillary carcinoma. So immunohistochemistry is not usually a defining feature or a critical feature, but it can occasionally be useful. Sometimes it can be confusing. So for example, TTF1 in a metastatic lesion could be thyroid, could be lung cancer. Thyroglobulin is usually positive in papillary carcinomas, and pancytokeratin, CK19, and galectin-3 and HbME1 are relatively more specific for papillary thyroid carcinoma, but they are not absolute. There are some false negatives and a number of false positives as well. Of course, if you're thinking about medullary carcinoma, a negative calcitonin is helpful. If you're thinking about other carcinomas from other areas, CK20 is of course going to be negative as well. In some particular variants, columnar cell variant can be CDX2 positive, and beta-catenin can be positive in the cribriform morular variant. So those may occasionally be helpful in those sometimes more confusing and challenging variants. So the WHO classification includes at least 15 variants, but and in the CAP checklist, we indicate which variant we're seeing, as that's helpful in monitoring follow-up. Classical form with classical nuclear features, and Papillary is the most common variant. But there are several variants that can be more aggressive, and it's important to therefore delineate those. So the tall cell variant, the diffuse sclerosing variant, hobnail variants, columnar cell variants can be more aggressive. And then additionally, certain types are almost benign. Papillary microcarcinomas, typically very minimal follow-up or treatment needed for those. The follicular variant, especially the encapsulated variant, usually fairly indolent. And the cribriform morular variant, which is quite uncommon, is also generally thought to be indolent. So let's talk about papillary microcarcinoma. This is defined as a small lesion less than 1 centimeter in diameter. So 10 millimeters or less, having papillary nuclear features. So here's a nice example of this. And we can see here at low magnification, the initial review has delineated this lesion as being right here, measuring that on their microscope as less than 10 millimeters. And as we look at higher magnification, we see that indeed it has nuclear clearing, it has nuclear crowding, it has some grooving here on some of these nuclei, a few macronucleoli as well, and bits of sort of sticky, dense colloid as well. So based on size, based on nuclear morphology, we make the diagnosis of microcarcinoma. Here's another example that's sort of pushing the size envelope a little bit. Again, it's a lesion that has predominance of follicular differentiation, follicular pattern, a little bit of sclerosis, and let's see where our well, the nuclear features on this one are not so great. I don't know if you have any annotations, no annotations. So this may actually be misclassified. There's a few atypical nuclear features. I'm not really satisfied that the majority of this is a microcarcinoma, because this is more the pattern of a follicular adenoma. It's very banal looking. There may be a few areas where we begin to get some nuclear features of papillary carcinoma, such as here. And so certainly classifying this as a microcarcinoma doesn't have any adverse survival differences for the patient, but may prompt a little bit more follow-up. Well, here we're getting more of the nuclear features characteristic of microcarcinoma, papillary carcinoma, clearing, nucleoli, grooving, overlap, and so forth. So sometimes you do have to be aware that these lesions can have only focal areas of papillary carcinoma features. Despite that, when it's an encapsulated lesion like this, you might be wise to measure the entire diameter of the lesion, not just the area which has the nuclear features. Alternatively, this may be a lesion which under current classification might fall into a different category, that of encapsulated follicular lesion with papillary nuclear-like features, which has been deemed to be entirely a benign lesion and is of just such a thing, only larger than 1 millimeter in size, or excuse me, 1 centimeter in size. Here's another example. Again, this is a patient who had bilateral lesions, but here we see a small 1 centimeter or less lesion, again with quite a bit of follicular differentiation here. But as we see, there's some clearing here. You can begin to pick this up at low magnification. You can begin to see at low magnification the clues that give you the notion to look at higher magnification and find these nuclear features. So we'll go back to low magnification so you see that. So you see there's just a little degree of pallor to the nuclei in this peripheral rim here. Of course, here we also see another feature. We see invasion through the capsule here. So this is not an NIFTP. This is an invasive lesion, but by size criteria, it's the microcarcinoma size classifies it still as having a very favorable prognosis. So let's talk about one of the aggressive variants, the tall cell variant of papillary thyroid carcinoma. As you see, this is not a common variant of papillary thyroid carcinoma, accounting for only 3 to 10% of these tumors. And the definition is, of course, that you have nuclear features of papillary thyroid carcinoma, and you have cells that are 2 to 3 times as tall as they are wide in at least 30% of the tumor. In addition, these tumors will tend to form rather long papillae, and they have quite eosinophilic and somewhat granular cytoplasm. So this is the key determinant, 2 to 3 times their width and height, accounting for 30% of the tumor papillary nuclei and long villus-like structures. So let's take a look. Here is a somewhat washed out slide from earlier versions, but we can see that we're getting sort of long, elongated papillae and villus forms here. So the architecture is somewhat sort of elongated structures. And as we look at these cells here, just look at how these are tall cells. So they're at least 3 times as wide as 3 times as tall as they are wide. Okay, so that's the feature, and that needs to be seen in about 30% or more of the tumor. And we can see here that's the case, here that's the case. So we're seeing it in ample areas in this tumor. And do we have the nuclear features that qualify as papillary thyroid carcinoma? Well, we have some nuclear clearing. We have some pseudo-inclusions right here. We have macronucleoli. We have nuclear overlap, coarsening of the chromatin, peripheral margination of the euchromatin. And so I think we have enough atypia here of the nuclei to qualify as papillary thyroid carcinoma type nuclei. Now, obviously, not all the cells, like right here, are taller than they are wide, or 3 times as tall as they are wide. But those are the minority compared to these other cells that we have here in this case. And as we indicated, you only need 30% of the tumor to be this way. So let's look at another example here. Here we can see one that's sort of extending and sclerosing into the surrounding tissues. Again, here we see some follicular structures, but some very elongated papillae type of tissue here. And again, these are rather narrow cells and fairly tall. We can clearly see the nuclear features with clearing, grooves, and so forth. And we get the sense that these are really quite tall cells relative to their width. They're somewhat crowded, and so the individual cells tend to get squeezed a bit. And that may be actually what this morphology is manifesting to us, is just a lesser degree of growth inhibition from neighboring cells. But I think you can see again the tall nature of the cells relative to their width. Here we see additionally some sclerosis, more of this elongation of the somewhat villus-like fronds. Here, for example, right here, we see just long train track type of patterns of these cells running through the tissue here. Now this is a lesser example. I think it's got a solid area, it's got a lot of follicular growth, but it does have one area over here which I think begins to come into the realm of tall cell carcinoma, as we see these longer areas here, again fairly tall nuclei. This is probably one where you might wonder if we have enough of the tumor to classify as tall cell. Notice that the nuclei here are also very enlarged and elongated in some of these areas as well. And we have sclerosis as well. In these other areas, the cells are not quite so tall. And here, for example, it's just typical papillary thyroid carcinoma type nuclei with a more follicular pattern. When the tall cell feature is less than 30%, what do? We don't call it tall cell carcinoma variant, but we can give a quantitative answer as to how much has tall cell features, and that may govern and guide treatment. So we use the term papillary thyroid carcinoma with tall cell components, or papillary thyroid carcinoma with tall cells less than 30%. And because this still has some degree of enhanced aggressiveness, this should be reported with some detail. So pay attention for those things and evaluate your thyroid nodules carefully, looking for that possibility. So another variant that is seen is the solid variant. And this is important to distinguish from poorly differentiated carcinoma, which we'll discuss later. This is often seen in patients who've had some radiation as an inducing feature, and it may also be more prevalent in pediatric populations. Again, we see papillary thyroid carcinoma nuclei, and we see almost exclusively a solid trabecular or insular type of pattern. So we didn't find a great digital slide to share with you, but I think you can see from these two images here, both the high magnification view with nuclear inclusions and the clearing and chromatin and so forth, that looks like papillary thyroid nuclei, but a fairly solid growth pattern. It's sort of an insular pattern, little islands and nests. It's not producing follicles, else we might think of it as a follicular type of lesion or a follicular variant. Now, one of the more common variants, of course, well, 5 to 10%, is the follicular variant of papillary carcinoma. And in some locations, it tends to be higher. Some consultants tend to call it more frequently than others. But this demands that you have almost exclusively a follicular pattern. In other words, no classical papillary structures. Lots of tumors, lots of papillary carcinomas have some follicular differentiation. But this is a tumor that is almost exclusively follicular. And these can be either infiltrative or encapsulated. But if it's encapsulated, then you must see capsular invasion or vascular invasion to define it as a follicular variant of papillary carcinoma. If it's not, then it's going to fit into that really benign category now of follicular neoplasm with papillary-like nuclei, or papillary nuclear-like features. So here's a nice example. We can see here lots of follicular differentiation. And I think you can see we've got a little bit of solid type tissue here, but even in these areas, if we look closely, we can see there are microfollicles here. So many of these areas are microfollicular pattern. But look at the nuclei as well. See how we've got grooves, we've got clearing, a few nucleoli. We've got features here that fit nicely with papillary carcinoma, but it's really exclusively a papillary pattern. a papillary nuclear feature type pattern. So then the question is, do we have capsular invasion, vascular invasion? Well, here's certainly some areas where we're seeing capsular thinnings. It's suggesting that we're getting capsular invasion and maybe some early vascular invasion. We'll talk more about what constitutes vascular invasion. But this is where you want to examine the full lesion, and guess what? Here we see, well, here's an area where the capsule of the tumor has been coming along, and then this has penetrated beyond, so you get a essentially a mushroom cap over the prior capsule. So this is clearly capsular invasion here by tumor. We can see again that these cells have the nuclear features of papillary carcinoma, follicular pattern, and that this pre-existent fibrous capsule here has been invaded, destroyed, with tumor extending beyond it. So that nicely qualifies it as papillary carcinoma follicular variant. Here's another tumor, taking a look at this one. This one is not particularly encapsulated. We've got sort of a sclerotic pattern here. But as we look through this, everything is follicular pattern. There's no papillary structures. There's no, even here, we're seeing, again, that microfollicular pattern. Even these small areas have little central cores of colloid. And the nuclear features, again, are those of papillary carcinoma. Cleared out cells, some slightly crumped chromatin, nucleoli. Here's a groove. So we're seeing those features that we have come to associate with papillary carcinoma. And it's diffusely infiltrative of the pattern of the thyroid. Another example here, we can see areas of sclerosis. So maybe if there was an initial encapsulated lesion, it is spread sufficiently. Again, it's got follicular architecture. Now, does this make it papillary? Do we see this degree of papillarity? Well, I don't think so. I think this is not quite a well-developed papillae. We would need to see better papillary differentiation, papillary architecture to classify this as a classical variant of papillary carcinoma. But we are seeing lots of infiltrative follicular type growth by these cells with overlapping and clearing and all the features that we've described for papillary carcinoma. So I think you're beginning to get the sense here of what constitutes these lesions. Here's another example here. Is this follicular variant? Well, I think this might be an example that we might not call, even though we have some nice follicles here and so forth. Here we're seeing more of this classical papillary architecture. So this should be better classified as a classical variant, even though it does have some follicular growth. And again, it's infiltrated through the capsule, and we've got outer growth here, beyond the capsule going on here. So this is not 100% follicular pattern, even though it was encapsulated and we've got growth and extension beyond there. I think there's some areas here that we should better classify as classical variant. Well, we indicated there are lots of varieties of papillary carcinoma. There are a few other uncommon variants that I have some slides for. One is the Wharton-like papillary thyroid carcinoma. So that, again, has papillary thyroid carcinoma-like nuclear cytologic features and architecture, but a very dense lymphoid-rich stroma, sort of like a Wharton's tumor. There's also a diffuse sclerosing variant of papillary thyroid carcinoma, which we've shown in some other work is a more aggressive form as well. So here's the first of these, the Wharton's-like papillary thyroid carcinoma. Now, Here, notice that we've got some background thyroiditis here. So we've got lymphoid tissue with some germinal centers. And this may be a clue in these situations to look for this. But then as we look here at our tumor, we see again, we've got this lymphoid stroma here in between the cells. And so is this just thyroiditis? And maybe we've got some Hertel-like cell changes. No, in fact, as we look at these nuclei, we start to see grooves, we see irregular nuclear membranes, we see some nucleoli, we see some pseudo-inclusions here and here. We see the nuclear features that are papillary thyroid carcinoma. And so we're not going to shy away from that because the patient has a background of thyroiditis. But as we look at this, we can see that there are other features of papillary carcinoma here. We've got a capsule with areas of certainly infiltration into the capsule and sclerosis of the tumor, papillarity to the architecture. And here's an area without much of that lymphoid stroma with typical papillary thyroid features. So finding and examining the whole thing and seeing where the features are here. Again, nice example of invasion through the capsule into the surrounding thyroid tissue. Nice little break there with this mushroom cap type of appearance outside the capsule. And the diffuse sclerosing variant has papillary architecture, but notice that it's got this very dense sclerotic pattern of hyaline fibrosis on all of the papillary cores. And so this diffusely sclerotic pattern is associated with a higher risk of metastasis and more aggressive behavior in these tumors. And again, we see the typical nuclear features of papillary carcinoma. So those are the features to be looking for in this variant. And notice that it's really throughout this tumor. It's the outer capsule, it's as well as the papillae within. And even though you've got large cystic spaces, each of these papillae, by and large, has a pretty dense hyaline papillary sclerotic core, almost like clear cell carcinomas of the ovary or endometrium, which can have this very hyalinized sclerotic core. Some of these tumors will also develop hobnail type cells, as you have with clear cell carcinomas as well. So let's move on now and talk about non-invasive follicular thyroid neoplasm with papillary-like nuclear features, NIFTP. So I've alluded to this before. This is a non-invasive encapsulated follicular variant of papillary thyroid carcinoma, but it is non-malignant. So it is not classified as something that bodes ill for the patient in terms of longevity. The difficulty, of course, is that this is a challenge cytologically to make this diagnosis without examining the entire capsule. But when you have a surgical resection and you see a follicular neoplasm with papillary-like features, be mindful of this possibility. So follicular growth pattern without papillae. It may have some homobodies. It may have some solid or trabecular pattern. It has nuclear features of papillary thyroid carcinoma, but absolutely no capsular or vascular invasion. And you should not also see much in the way of mitotic activity and no necrosis. Those are uncommon in papillary carcinoma to begin with. But how do we know there's no vascular capsular invasion? The only way that we really know that is by embedding the entire capsule of a thyroid nodule. So that is the standard of practice in our institution, and one that I recommend if you're going to avoid overcalling these as papillary carcinoma and potentially overtreating them, because these are not patients you want to be necessarily giving radioiodine or even completion thyroidectomies. Okay, so moving on to follicular thyroid carcinoma. This is the 10 to 15% of cases. These are not uncommon, but they're not as common as papillary thyroid carcinoma. These tend to be older age patients and to have somewhat larger size at presentation than papillary carcinoma. And they tend to metastasize hematogenously, hence to bone or to lung and so forth. But they're highly treatable. These do respond to radioiodine treatment. They do respond to other modalities to suppress them so that the patients can have a nearly normal lifespan. What we see is a follicular pattern, absolutely no papillary thyroid nuclear features, and capsular or vascular invasion, which again requires very extensive sampling of that capsule. And this invasion can be either localized, a single focus sort of thing, or what's termed minimally invasive, or more extensively present, and then in which case it's called widely invasive. So what defines capsular invasion? Well, I like this little diagram that comes from Dr. Fletcher's book. And this classifies things that are and are not, things that are maybe suspect and could become, but are not yet. And so here you see extension of tumor beyond, through the capsule, beyond into surrounding thyroid tissue, yes. With a thinned fibrous cap over the top of such a thing, that also is yes, because you've penetrated the capsule and then this fibrous tissue will be secondary reactive fibrous tissue. Separate island of tumor outside of the follicular neoplasm, yes, presumably you've just cut through this at a different plane or this in a different plane. So this also represents such thing. And sometimes this pattern of spread is what I've referred to as the mushroom cap spread. Seeing this incompletely through the capsule is concerning, but does not of itself qualify as invasion, and therefore may still be a benign lesion or technically benign. And these other patterns likewise do not qualify as invasion. Vascular invasion, similar diagram, also from Dr. Fletcher. And here again, we see things that are and are not. So if there's a continuous connection to the follicular tumor and a little bit of endothelia over the tumor in a sort of thrombus-like pattern, that's okay. Here you see, again, tumor in a vessel with red endothelial cells lining it, that's okay. If you see a little thrombus and tumor, thrombus, fibrin, blood cells, etc., associated with tumor in a vessel, yes, that's okay. Outside the tumor, yes, that's okay. Tumor fragments, no blood fibrin attached, no endothelial attached, could be artifact. So we don't call this a vascular invasion. Likewise, vessels within the tumor that are ectatic and may have indentations or ingrowths of tumor don't yet qualify as vascular invasion. So those are helpful criteria. There's still obviously an important role for pathologist interpretation and evaluation to make the best decision for the patient. And obviously extensive evaluation, sometimes with levels and additional sections may be useful because this is an important distinction in terms of management. Okay, so here's an example of a tumor. We see it here. It has a little bit of a capsule, but we can see that we have extensive amounts of tumor outside the capsule, here. And so we don't need to even ask the question, is this malignant? Is there invasion? Because we see it at low magnification, that there is extension far beyond the capsule. And looking then, we have to answer the question, is it follicular or is it papillary? We see there's a fair bit of eosinophilic oncocytic cytoplasm here. This could be a Hürthle cell variant of follicular carcinoma with this degree of oncocytosis. Prominent nucleoli, that's not, this type of nucleoli is not a feature of papillary carcinoma. See follicle structures, colloid, a lot of these eosinophilic oncocytic cells, some hemosiderin associated with areas of tumor. Surrounding tissue, thyroid parenchyma, looks benign. Again, doesn't have things, but here we see out here, this is tumor, this is a vessel, this is tumor overlying with endothelial overlying it, this is vascular invasion. Similarly, we could account for this feature here, just barely covered by endothelium, maybe in vascular invasion out here as well. And we can evaluate these other areas of growth far beyond the main tumor mass. Here's some, here's some, here's some. So this is widely invasive follicular carcinoma with Hürthle cell oncocytic features. Here's another example of a neoplasm. Here we see a capsule, a little bit of a thin nature to it. Let's see here what the top of it looks like up here. And here we can see some of the areas of concern. So we'll focus down on here. I think you'll believe me and say, okay, this is outside of the capsule, and it looks as though we are inside a blood vessel here, or at least could be, but at least this is capsular invasion, if not vascular space invasion. This might be vascular space invasion. We might want to do an endothelial stain, for example, to see if we have endothelia lining this space here and these follicular type cells. So again, we have to answer the question, do we have any features to suggest papillary carcinoma? Well, we see some nuclear atypia here. We don't see the clearing. We don't see the nuclear inclusions. We don't see the same degree of overlap. And we're in a totally solid or follicular pattern of expression here in this tumor. Not the best section, of course, I apologize. Some artifacts here. We can see these nice follicular structures. So minimally invasive, at least on the basis of this slide, with capsular invasion of a minimal degree. Here again, a nice nodule. We see a little scalloping. This is not capsular invasion there, but certainly makes you want to evaluate the full thing. Here again, another feature of a dilated ectatic vessel with sort of tumor trying to probe its way in there, perhaps a little bit. And we see follicular structures. Now here we do see a little bit of nuclear clearing, a little bit of overlap. So we could begin to wonder about papillary carcinoma with follicular features and invasion, because this certainly does have some features of nuclear features of papillary carcinoma, and we can begin to see that here. So these are challenging. The feature, of course, of importance is capsular invasion, and this is just one section. But we're beginning to see thinning, and so if we were to begin to see any sort of tumor beyond this, we would be more concerned about carcinoma. But on the basis of this section alone, I don't think we can make that diagnosis. But it underscores the importance when you begin to see this sort of thing to look for that in all of the other sections. And of course, as we've done, to evaluate for nuclear features suggesting papillary carcinoma. So here, as I've mentioned, the minimally invasive variant, and this is capsular invasion. Angioinvasive is another category, encapsulated angioinvasive, less than 4 vascular invasive foci, and then widely invasive. So we'll look at a few more examples. Here's a low power magnification view, and we can see if this is follicular carcinoma, this is widely invasive by definition. You've got tumor far beyond the capsule. And so we'll take a look at here and see follicular architecture. No papillary carcinoma nuclear features. And here's similar tumor outside here. Similar nuclear features, similar architecture, differing from the underlying benign thyroid parenchyma, multiple nodules. So this qualifies as widely invasive follicular carcinoma. Now, this nodule here looks a little different. Certainly looks different than these or these. Is this a part of the carcinoma? Should it be measured as such? And I would say probably not, because this still has more of the features of a follicular adenoma rather than a follicular carcinoma. So whether this arose from this can't be determined per se, but it's not uncommon for some of the early molecular changes, KRAS mutations and specifically, to be seen in these follicular adenomas, and then to be carried over into the follicular carcinoma component. Here's another example, nodule, demarcated capsule on all 3 sections. And you can see here, this is one of the ways we're trying to evaluate the entire capsule, is just by putting through thin sections of the capsule. And here we can see one of these little mushroom cap type of projections through the capsule. So here's the capsule coming along here, continuing on here, but here's the gap, and tumor extends beyond the capsule. And then we get a little secondary cap over a portion of it, perhaps. So this would be certainly one marker looking for capsular invasion. You can see that the cells do not have papillary features, no nuclear features of papillary carcinoma. And we, of course, want to evaluate the entire capsule to see, do we have other features? Do we have angioinvasion, et cetera, et cetera. Here's another lesion. At low magnification, this is a little bit harder to see that it's follicular, but as we come into higher magnification, I think we can see that there's a solid and microfollicular pattern here, very small follicle structures. We don't see papillary carcinoma nuclear features. They're generally round, uniform nuclei. So then the question is, do we have capsular invasion with this lesion? Well, adenomas typically have a very dense fibrous capsule. And here we can begin to see early invasion in one of these. Here's more of that pattern. So in this section, we see several areas where we're beginning to see capsular invasion, but we don't have established fully penetrant capsular invasion. So this should prompt us to look further to identify more sections where we can prove without doubt that this is follicular carcinoma of the minimally invasive type. Additionally, we can, of course, look for evidence of vascular invasion, either within the lesion.